Okay, that's working.
We hate new computers. Okay, my name's Alyssa, and this is my respiratory cardiac physical assessment video. I'm going to start with the respiratory, and this is my patient. So at first, when you first walk in, you're going to look at the posture of the patient. When the patient is sitting upright, that means that they're getting full chest expansion, lung expansion, which means that they're getting enough air in their lungs and to the rest of their extremities. Then you're going to take a look at their skin. We're going to notice that his skin is warm and dry. He has hair bilaterally on both of his extremities, which means that he has good blood flow. And then I'm going to have you go like this with your fingernails, and we're going to measure the tips, which is 160 degrees, which is perfect. And then we're going to take a look at your conjunctiva. Pull down. It's nice and red, and it looks healthy. Next, what we're going to do is we're going to take a look at his pulse. It's regular, not bounding, not racing. Awesome. So now for the respiratory assessment, what we're going to do is we're going to palpate the back with this part of our hand. Basically what we're looking for is tenderness and pain. So I'm going to ask the patient to turn around for me. And as I tap on your back, tell me if there is any tenderness or pain. No?
None.
How about here?
Nope. Good.
Okay.
Still good.
Okay. Awesome. Any tenderness or pain anywhere?
Nope.
Awesome. So next what we're going to do is we're going to check thoracic expansion. So with my thumbs, I'm going to just place them down here on the patient's back, right underneath his lungs, and I'm going to ask him to take a full breath in and out, and I'm going to test and see how good his lung expansion is. Good. So your thoracic expansion is good. I can feel you breathe in and out fully, and that's exactly what we want to feel. So next what we're going to do is we're going to do tactile fremesis. So with the same palms of my hands that I did for the tenderness, I'm going to test vibration. So when you feel my hands on your back in different areas, what I want you to say is 99, and I'm going to work my way down your back, okay?
Yep. 99, 99, 99,
Yeah.
99, 99, 99, 99, 99.
Perfect. So I can feel vibrations from the top where I started all the way down, and that's what we want to feel. So next what I'm going to have the patient do is I'm going to have him give himself a big bear hug, and we're going to percuss his lungs. We do this by taking 2 fingers and tapping, moderate to light to see if we can feel any fluid or masses. Right. So let me know if this hurts, okay?
Yep. Nope. 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 Nope.
Okay. So when we test percussion, it is something that takes time in order to develop this skill. So it's something that I'm going to have to continue practicing so that way I have a better idea of what I'm looking for during a physical assessment. So next what we're going to do is we're going to do diametric exertion. So what I'm going to have the patient do is I'm going to have them breathe in and out, and I'm going to mark on pieces of tape the exhale fully and then the inhale fully, and we want that space in between to be 4 centimeters. So what I'm going to have you do is I'm going to have you inhale and then exhale all the way. Perfect. And now I'm going to have you inhale fully and exhale for me. Perfect. So I'm looking at the space right now, and just using my fingers and not using tape, I am able to see that this is less than 4 centimeters. So that's exactly what we want. Next, what we're going to do is I'm going to auscultate the lungs. And just so you know, the diameter exertion you would do bilaterally, both sides, to make sure that they're even. You percuss bilaterally as well. And with the palpate and percuss, you do that anteriorly and posteriorly, along with auscultating the lungs, but I'm just going to do them posteriorly today. Okay. So I'm going to listen to your lungs. If you feel lightheaded at all, I just want you to raise your hand and tell me, okay? Take a deep breath. Awesome. Your lung sounds are clear, which is exactly what you want. And I would do that all the way down the back, and then, like I said before, anteriorly as well. So now moving on to cardiac. So I'm going to have you face me now. We would start the cardiac assessment by first finding the sternal notch, which is right about here. From here, we would go down 2 intercostal spaces in order to find the aortic area, and then to the left of that is the pulmonic area. These 2 areas are 2 places that we would auscultate. Now going down to the 3rd intercostal space, this is the Erb's point. Down to the 4th is the tricuspid, and then the 5th is the mitral, and then almost right next to the mitral is the apical. These are where we listen to our heart sounds to hear S1, S2, S3, and S4, and also hear any murmurs. So what we would do first, before listening or percussing anything, is we would inspect the patient. So we want to watch their chest rise and fall, make sure that their heart isn't pounding out of their chest. There's no jugular distension. There's there's nothing extra going on. So what I notice is I'm looking at the aortic pulsation. Sometimes you can see it right under where your mitral and apical spot are, and then for those people that are really skinny, you can actually see it in their belly button as well, and that just shows their heart is beating normally. And this can be a normal occurrence if they don't have any other cardiac problems going on. So for our patient, we do not see the heart beating out of the chest. We do not see jugular distension. And normally we would use a tangible light in order to put more focus on the area so we know what else is going on. There's no extra fluid that I can see. Okay, so now what we're going to move on is I'm just going to put my hand over his chest and feel apical pulse and see how, sorry, he's fine. So we're also going to feel for vibrations, turbulent vibrations, which would indicate for a murmur. When I was feeling before, I didn't feel any turbulent vibrations, which is a good thing. Next, what we're going to do is we're going to auscultate. So we're going to auscultate the areas that I first talked about before. We're starting with the aortic area. Moving on to the pulmonic area. Erb's point. Tricuspid. Mitral. And apical. So S2 is louder at the top where the aortic and the pulmonary landmarks are. S1 would be louder if he had a murmur, which he does not, which is a very good thing. And at the Erb's point, we can mainly hear S1 and S2. At the apical point down here, the lub is louder, but there's no S3 or S4. And then we would check the lateral side, which I did with the tricuspid. And we would do that by using both the bound and the diaphragm of the stethoscope. Sorry, I have to turn mine on. And his heartbeat is regular. It's not bounding. It's not going. He's not having a tachycardic or a bradycardic moment. So then what I would have the patient do is I would have the patient lean forward. What I'm basically looking for is I'm looking at your aortic and your pulmonic landmines, and we're just checking to see if you have a murmur, even though I've said before that you don't. Okay, awesome. And then finally, at the end of our exam, we would go through the vascular system and just make sure that all of his pulses are equal bilaterally and are present bilaterally. So we would start at the top with the temporal, pushing. So these are +2. Then we would go down to the carotid, and we only would do one at a time so our patient doesn't pass out. This is also +2. Moving on to the brachial, which is right here, and you would just have the patient hyperextend their arm just a little bit. This is also +2. And then the radial and the ulnar, and you want to be sure not to use your thumb because your thumb has its own pulse. And then if the patient was laying down, I'd be able to show you the popliteal, which is right behind the knee, and then the dorsalis medius and the posterior tibius pulses as well. Thank you.